semi-specific technique with a lot of input going in of a non-nociceptive variety, stimulating the soft tissues, stimulating a little bit on the ribs themselves through the pressure on the periosteum, and also doing some movements on the joints at the back. Now, the easiest movement, of course, to do as far as the costotransverse joint is concerned is to do a forward movement, of course. So can you lay on your front, please? Now, if we're into doing a forward movement of a particular rib, then what we should make sure is that that particular rib is not held by the bed. Now, these beds wouldn't hold it, but if you're on a much harder bed, perhaps we should be a little careful. And so it would be a good idea to take a very flat sandbag or something like that and just place it in a comfortable way on perhaps both sides of the rib at the front here, so that that rib has a little space, so that when we push down, it's not being stopped by anything. So now I can come in, palpate the rib here, and I'm simply going to take the rib to start with, superimpose my hand over it, and just push down gently. Now this is only a semi-specific technique because I'm not stopping the vertebra from moving. I could try and lock the vertebra, couldn't I, by extending it a little bit, side bending this way, which would rotate it that way, and that would kind of stop this sort of movement. But what's happening for the vertebra is I'm carrying the vertebra that way, so I'd have to try and rotate the vertebra in that direction. By far and away the easiest way to do this is simply to use that technique that we used for examination, which is to block off the vertebral movement and to push like this. And if you've got the thumbs that bend backwards at an angle of 120 degrees, perhaps you don't want to do that, so you take the thenar eminence or the hypothenar eminence like this, come round like this and push downwards, or I can push a little bit more laterally, which I think is probably putting a bit more stress on the costovertebral joint. So I pick up the vertebra and I push out like that, coming down here. So this will get the costotransverse, a little bit costotransverse glide with the costovertebral. But remember, those big thick ligaments there are resisting this a bit. So this would be a useful technique. Now, we can do all of those techniques in the supine position, similarly to what we did yesterday when we were doing supine. All we have to do now is, instead of getting onto the vertebra below, the most caudal vertebra, we start to put our fingers on the transverse process, or not the transverse process, on the rib, making sure it doesn't go onto the transverse process. So, where is the spine? What we'll be doing in the supine position is this. I will be putting my thumb on my hand like that, and I'll be placing my thumb against the angle of the rib there, making sure that it does not extend over the transverse process. Now, by taking the spine and moving the spine into rotation to the left, the rib can't follow it because my hand is stopping that, and so the joint that will be gapped will be the costotransverse joint. Now I can do this semi-specifically by just, if it was very stiff and I was doing 3 or 4 or 5 joints, I would just rotate the spine that way, not with any big deal. But if I wanted to sort of manipulate that joint and I wanted to use the spine here to do it, then I'd have to go into the combined movements, the non-physiological movements of the spine that are related to left rotation, and then push those back while I stop the rib from moving. And so these techniques are definitely a progressive thing, the same hand positions, the same everything, it's just whether you do it or whether you, is the only difference between whether this is manipulative or whether it is mobilizing. So, where we can get our hands on, which is probably in the 4 right the way down. It's a little bit difficult when we take the 2 and the 3 because the angle of the rib there, the angle of the scapula there tends to get a little bit in the way. Even though if we put the hand here or like that, we tend to abduct the scapula at the bottom, we can do it, but the top is still moving in a little bit. So it's hard to get in there, and I'll show you the modification for that. Now, can you lay on your back, sir? So here we go. We've got that side lying. This is pretty well the same. I'm going to put his arms across here. And this is one advantage. I'm going to be working on this side. And by using this arm that's closest to him, or closest to me goes closest to him, then I've got all sorts of space here. Whereas if I were using this and trying to push from the back, what's happening is it's stopping it from the front, and this could cause problems as far as fractures and things like this are concerned. They say that all manipulators fracture a rib at some time in their career. I've made some very sore earlier on. I hope now that that would never happen. And I think with you, because of the skills you're getting with mobilization, it shouldn't. But when we were certainly coming, and using far more force than was necessary, this was a consideration. And in those days, of course, nobody ever sued anybody, but now they do. And so we have to be careful. Let me just roll the patient a little bit towards me here, keeping that sort of orientation here. I'll palpate the rib that I've marked or that I'm sort of trying to go. I can use this position, as I said yesterday. I can do a little bit of extension, or I can do a little bit of rotation to kind of identify where we're going to go. So now I use this. I'm coming onto here. I find where the transverse process is. I get my thumb up close, but making sure that there is no chance that I'm over the spine at the transverse process, because if I am, the way that this works is the transverse process has got to be able to go posteriorly and the rib not be able to follow it. But if I'm up here somewhere, the transverse process can't move, therefore the technique is of no value. So I'm going to come round the back here, place my hand on, make sure that I'm as close to that transverse process as I can, but not onto it. And now I'm just going to simply rotate a little bit like this. Now, if I were just doing a sort of semi-specific technique, notwithstanding that I don't like him to go into extension, this generally doesn't cause any problems. I would just gently push him over till I feel my thumb is in contact with the rib, and just a little bit of a gentle stretch like this. The lower down I get like this, just to avoid any problems of going back too much into extension, I'd lift the end of the bed a little bit, so I'm kind of pushing back at this angle. Now, once I want to become more specific, I mean that's specific enough, but it's semi-specific. If I want to be very specific, what I have to do now is to try to eliminate the spinal motion, so that the whole spine is working as a rigid lever, and it doesn't matter if I lock through the spine, so long as the spine is a rigid lever for that rotation, the rib just cannot follow that rotation. And so I would be using this in slight flexion with our time-honored way of side bending towards me, which would rotate him this way. That means it's got resistance for rotation that way, which I'm using as my lever force, a rigid lever now, because I've got resistance for that. And now I would make sure that the rib doesn't follow. So here we go. I come into here, feel the transverse process, onto it here, come up a little into flexion, because that is the combination of side bend rotation I have to use against flexion. So I now come into here, side bend down past that bone, and now I just rotate, and that's getting a very much more specific motion here. So I can just move down against that rib, and that will be the way that into there and just there for the manipulation. That would be the difference. Just the all the way through, yeah, and just sort of then we just, as we come back, the rotation is probably, I mean, when we talk about locking and we sort of say that this rotation can't occur because I've got that side bend, obviously a little occurs, because I mean this is not rigid concrete, it's all got resilience. And even if you've got facets like this, there's a degree of plasticity in those facets which will give a little bit of movement. So we can go way past there and then just go round, and this is a very precise technique. All right? So those will be the, yes sir? Oh, there. And so the transverse process goes back into that space. So here we have, I'm going to be round here in that way here. I side bend the spine this way in flexion, which rotates it that way, so that when I rotate back here, this is a rigid lever, and that rigid lever is being forced to the left-hand side, but the rib can't follow because I'm blocking it. And so then when I just give a little bit more movement, I'm taking the spine that way, but the rib can't come, and so it gaps that joint. And presumably it puts a bit of distraction also on the costovertebral joint.
Is it the lateral side of your thumb?
Yes.
Okay.
Yes. Yeah, that side. And I've got the tongue on the roof of my mouth. So everything is good. Any others?
I just have a question. It seems like you keep doing a coupled movement and then you superimpose a combined movement. You did it yesterday,
Yep.
and now you're doing it now.
So coupled is semi-specific,
Right.
combined is specific.
And then you manipulate.
And then from a specific mobilizing, that's going to be now the only difference between a specific mobilizing and a specific manipulation is the speed with which you enter the barrier. That's it.
That's what I was going to ask you.
We've had a breakthrough. Good. Any other question? Oh, let's do these because they are so satisfactory. Very good. Scoliosis, and is there any value at all in just kind of mobilizing a scoliotic spine? Tell us your experience.
Well, just that's how much right rotation I have today. I don't know if you remember, but I mean, like yesterday was like here, and I mean, it's not painful at all. I noticed that last night, backing up the car out of the parking lot here, all of a sudden I could look over my shoulder instead of doing that, and it stayed. It really feels good.
Okay, thank you. So, it is well worthwhile. A stiff scoliotic spine is probably more vulnerable to stresses and pains than a mobile one. You know, same as a stiff flat foot is worse than a mobile flat foot. And so I think there is some value, and I don't think that any of us have the capacity to sort of keep our fitness levels up at a sort of peak. Perhaps we do need to sort of tell people to come in occasionally, and we just change our goals, that we are helping her to maximize her physical performance instead of feeling every time she comes back, oh God, I couldn't have taught these exercises properly, as if it's like a fault against us. I mean, we all know that we back off. You know, you lose a bit of weight, you're never going to put it on again. 6 months later, 96% of people have put it all on again with 10 pounds. You know, this is the human dilemma. And so perhaps we can help to keep people more functional all the time. Now, what we did was this. We had a look originally and found a sort of a problem. We had two ways we could go here, that the whole sort of spine was relatively stiff and the whole of the chest wall was relatively stiff, or we found one or two that had a particular stiffness. Now, if everything is stiff, to go for individual bones would seem to be pointless. We should just go for a sort of a generalized loosening to see what that does. And so that's what we did originally. We looked for, can we use the spine a little bit in that sitting position? I can do some soft tissue work and get a little bit of extension. Or I can have the patient laying on the back with their arms around here, and I can use that extension here, and I can add a little bit of bucket handle, I can add a little bit of pump handle, and then as I recover I can push down. So I'm just getting a general kind of loosening of the spine. Now we're into the business of how can we look at the pump handle and the bucket handle restriction. Is there any point in trying to restore that if at the back we've got a lot of stiffness? We know that the structures at the back have a material, huge effect, a small thing at the back, on what's happening at the front. So it would seem to be best to just do some very specific things on the neck of the rib and the head and the transverse process of the vertebra, because it represents such a large improvement at the front. So regardless of whether we've got a bucket handle or a pump handle restriction that we've found, it would seem that the next procedure to do is to free up the costotransverse and costovertebral joints. And those were the procedures that we did. And we did some that were kind of semi-specific and semi-specific with massage, and then we saw we could use the whole of the rib lever against the spinous, or against the rib, so that the rib would sort of move into that wouldn't be able to move onto the thumb, but the transverse process would move into the space. So we can get more and more specific. And then ultimately a specific movement, as someone suggested, then just becomes a manipulative movement if we do it a little quicker, as opposed to if we do it just that little bit slower and approach the barrier. So those are all the same things. Now, just for the last two things, to have a look now at the pump handle and the bucket handle movement, if you could just lay on your back for a second here. We've tested in this range of doing the pump handle movement now. So I shall come into the position here. I will go onto the rib in this position. This is the where I'm finding, let's say between the third and the fourth rib, that there is a restriction of the pump handle movement, and that when I feel this, I come up to a position here and I feel that the rib is staying down on the fourth rib. So what I do is hold the fourth rib and don't let that come up on the fifth rib, and then through the arm I just stretch up into this pump handle movement. And I would perhaps encourage her to just breathe in a bit and let it go. And this is what I'm calling pump handle inspiratory restricted lesion. It's held expirated, but if we say it's inspiration restricted, then we don't have any problem with knowing what to do. So we hold down 4 and move 3 against 4 through the arm. Now, if when we lift this up here, we feel that 3 and 4, and when I ask her to breathe out, that 4 staying up on 3, then what I would do is to come into the position of expiration, hold 3 by the arm, and push 4 away from 3. So I'm going to hold 3 in its inspired position, then I'm going to push 4 away from that to try and encourage its correction of when it goes into the expiration motion. So for an expiration restricted lesion, I hold 3 through the arm and I mobilize 4 through my thumb with a respiratory assist, which of course is the expiration motion. And those two things are highly effective, very simple for the pump handle, and exactly the same for the bucket handle, which I would do in side lying. So if you could face that way, ma'am, please. I'll come into the side lying position. I've got the angle of the rib coming down here. I palpate that sort of motion there. Is it an inspiration or expiration? If it's an inspiration, an inspiration restricted lesion, I hold the lower rib still and I move by giving a little bit of a traction movement through the shoulder here so that I don't just strain the shoulder. Okay, so she breathes in and I move. And she breathes in and I move. And she breathes in and I move. Great. And then if it's the expiration, I hold the 7 in its still position through the arm and I push 8 away from it like that. These are both Olaf Evian's techniques. He does it with a little bit of muscle. Hold there. Now relax and push down again. Okay, now try and resist me here a little bit. And down again. Like that. So he adds a little bit of kind of intercostal activity. Now which intercostals are working? Well, we know that the internal works on expiration, external works on inspiration, I mean. On expiration it's the internal, but probably the intercostals are working very much more to provide a controlled and an elastic wall between the ribs. And when you see patients that are paralyzed, when you see with polio patients, they have these huge great gaps between the ribs, and the tissue here would move up and down because they hadn't got this elastic membrane that's controlled by with its muscle fibers to stop and to tighten and make the wall kind of like a completely solid wall here. So this used to suck in and out and was very inefficient, of course. And so we can actually work some of those muscles, whichever ones, hold in and just try and get this rib together here. But of course, when we're trying to get an expiration restricted, we get her to breathe out. So those will be the inspiration and expiration restricted lesions. Now, just so that we can kind of continue in two techniques that are not all that difficult, I'd like to just show you how we can gap the costotransverse joint now in this upper area where we have a great deal of difficulty with the position of the scapula. So we just go back a little bit, but I just wanted to get straight on with that whole little plan of where we go with the bucket handle and pump handle movements. Now let's just look at an area that might be a little difficult. And what I'm saying to you is that down here, because when we slightly alter the position of the shoulder, we get this abduction motion of the scapula here, and we've got to feel in this space here, which is very difficult. We can put our hands here, but what do we do up here, because the scapula is getting in the way? Why didn't I think of this, that I'm going to show you now? What we do is, instead of that, we do that. And that just fits in nicely, like that here. So we just do this. This is Olaf Evian's great suggestion. Cliff Fowler thought this was the best thing since sliced bread when I showed him this. We used to really struggle with the second rib, but now it's relatively easy. We can lock the spine right through that point with a slight flexion, side bend towards us, rotation away from us, which will lock up sort of in this sort of whole area. Is it bothering? Do we have to bother about those first 2 or 3 ribs moving in a different direction? Perhaps we should, but it seems to work okay anyway. Just lay on your back, please. So I will put this leg down, bend this one up, put the arms across like that, come down into here, and see now by just putting my fingers, you can see here's the thing. I couldn't put my hands across there, but when I can do this, I can get in and not go over that transverse process there. And so now I'm going to just keep her head up, and I'm going to look for where the lock is the best in that slight bend position. If I turn this way, does it feel softer than if I go to the same side? Now that feels a bit, and that would suggest that the upper thoracic spine is moving the same as the neck. So I side bend this, and okay, and there we can kind of manipulate that rib, which is the sort of second one down, just doing that way. And this is a wonderful way of getting at the second and the third ribs, just using that same technique, just putting your hand like that and getting it in where the scapula is obstructing us. Wonderful little improvement there.
Is it the distal or the proximal phalanx that's over?
The transverse process is going on the tip there. So we're trying to put this on the angle of the rib, but it doesn't extend over the transverse process. So the transverse process drops down there. It is just an excellent technique, this. It impresses me every time I use it. And then what we've got to do for a few moments is just to discuss first rib, and then we're into shoulder girdle. Oh, wow! Okay, let's just try those. Inspiration, expiration restricted for bucket handle and pump handle, and then just go back and think, right, if I'm having difficulty with a gapping of the second and third rib, how do I do it? And that's the way we do it. Then we finish that. Thanks, man.
You're welcome.
We sort of did. That's what
The inspiration, expiration restriction, okay? The plan would be to sort of feel the whole ribs and everything. And as we felt in our original examination, here's a problem of inspiration, expiration. So we now ask ourselves, okay, where can I get the best response? And the best response is going to be to go to the back and just make sure that free is free at the costotransverse and the costovertebral joints. And we've got some excellent techniques just for gapping that. So now we go back to looking at this. And if we still see there's a slight problem, having known that mechanically we've actually loosened this up quite significantly, then perhaps it's to do with muscles that are tight here. Perhaps the movement has been lost. If we can do that in the head, I don't know that we can actually have an individual loss of a rib movement, because it seems that if this is being driven by the diaphragm and so forth, that it's got to sort of be pushing up on these movements here. But we come to the front here, we feel for the inspiration restricted lesion, I lift the arm here and I feel that the T4 or the rib 4 is not moving from rib 5. So I take it to a position here and rib 5 wants to move. So I simply hold rib 5 still with my thumb, and by taking up the arm a little bit further with a distraction motion, then I move the 4 into inspiration. Now then, If we're looking at the expiration restricted, we go down, we find that the expiration, now that 4 seems to be stuck, or 5 seems to be stuck up on 4, and it won't go down. I hold now 4 in its inspired position a little, and I push 5 away from it. Okay? Holding the upper one, either mobilizing the upper one with the arm or holding in the expirated things, holding it through the arm and then moving the lower one into expiration. Now, the muscle energy people have got 2 days on ribs. All right? And I certainly could show you a whole lot of these muscle energy procedures. My feeling is that these very specific passive movements are highly effective. And when you look at some of the movements that they do with muscle, you ask yourself what muscle could be doing that and how is it doing it? And you have a great deal of trouble correlating what could correct that and what the muscles are doing. So, I think that we've got an excellent group of passive movements, but perhaps we should be extending our knowledge a little bit into the muscle energy group, and some of you members here have done that, and so perhaps you could have a sort of self-generated seminar. And certainly through Williams and Wilkins now, there are a whole set of tapes produced by Greenman on all of the muscle energy techniques. There's 9 tapes, $495, but you can buy them separately for about $80 or $90 each. I wouldn't bother about the first 2 about lead, palpation, all that kind of stuff, but perhaps to get the one on the ribs or this as a group would be a very, very good thing to do. And you could see that. And Greenman has got world reputation.
We have one of his texts that I really like.
Yes, okay. And that's manual therapy, or manual medicine, yes. Yeah.
They have it in the library.
Yeah, it's a red back book and it's not all that expensive. Very nice pictures in it, well worthwhile getting. Okay, let me just ask you a question for a moment. We've done the Cyriax examination of the upper limb and the upper quadrant, the whole of the upper quadrant, and when we looked at this, from our questioning of the patient and perhaps for some observations, we have in our mind a suspicion that we might be dealing with a thoracic outlet syndrome. Now, what would be the symptoms and the signs of the various kinds of thoracic outlet? That's what I'm going to give you 2 minutes to do, or 3 or 4 minutes, depending on how much you know. And then I'd like you to ask yourself the question, is there just one kind of thoracic outlet? Or the thoracic outlet has length, and if it has length, are there different structures at each area that could actually threaten that we could make a difference with? And I think we've got to recognize at least 3 sites on the thoracic outlet tunnel that can threaten the structures that are coming through. And at least 2 of these we can make a difference to.
So do you want signs?
Well, just sort of talk. Okay, why would we be getting a suspicion of a thoracic outlet from the Cyriax thing? We've got to sort of trigger, it's got to trigger off something in our mind with some questions. Okay?
One quick question, sorry, in that last technique you showed the second, third rib, the gapping of the cross transfers. Did you, when you looked for the position to mobilize it,
No tightness. I was trying to see which way to sort of side bend the spine. Would it better if I went towards or away? Because here we are at an area where it's following a type 2 rule. It's the same as the cervical spine. Whereas the rest of the spine, we're kind of thinking about it as a type 1. You know?